All attendees are in listen-only mode.
Hi, good afternoon, everyone. We want to apologize for the technical difficulty associated with the phone number. I was just on the phone with GoToMeeting troubleshooting. If you are having problems accessing the phone line, there is a link that says having audio difficulties. If you click on that link, there is a phone number that appears, and I have typed that phone number in the chat box, so hopefully everyone will see that. Okay, so we're going to go ahead and get started, and I'd like to welcome you to this afternoon's webinar, which is called A Continuous Quality Improvement Approach to Organizational Cultural Competence, and this will be presented by Dr. Thomas Leviste, who is our Center Director, and myself. And if you experience any other technical difficulties during the call, if you could please call the number that is listed, and that number is 1-888-259-8414 or 1-805-617-7002. Dr. Leviste, do me a favor. Could you mute for a second, please? Thank you. Okay. So a couple of housekeeping rules. If you would like to participate in the Q&A portion of today's call, you will need to have an audio pin activated. If you click on telephone, it will give you an audio pin. You will need to enter that number and enter pound. Otherwise, you may not take full advantage of the audio capabilities. If you're on a Macintosh computer, Mac is not compatible, GoToMeeting is not compatible with Safari. So if you are not able to see the screen or the slides, please try using either Firefox or Google Chrome. And also, too, in order to be counted as attending today's webinar, if you only participate in the audio portion and you do not click on the link to GoToMeeting, we do not register as having you as a participant. So if you are near a computer, please remember to click on the link that you received in your confirmation email. Thank you very much. And now I'd like to turn it over to Dr. Leviste.
Hello and good afternoon. It's a pleasure to talk to you about this issue of cultural competency in healthcare organizations. We have a lot to share with you today, and so we're going to get right into it. The presentation outline is on your screen. We're going to review the demographic changes happening in the United States and how that is impacting the healthcare system. We'll talk a bit about definitions of cultural competency, talking about the regulatory changes that are occurring within the healthcare industry as it relates to cultural competency. Then we'll provide you with an overview of the COA360, which is the Cultural Competency Organizational Assessment 360, which is an assessment tool that we created here at the Johns Hopkins Center for Health Disparity Solutions. And then finally, we'll mention the CQC, which is the Culture Quality Collaborative, a group, a membership organization of healthcare organizations that we manage here at the center. So could you go to the next slide, please? So first, a little bit about us. We are the Hopkins Center for Health Disparity Solutions. The center was established in 2002 with funding from the National Institute of Minority Health and Health Disparities. We are a designated National Center of Excellence in Minority Health and Health Disparities. And I am the director. My name is Dr. Thomas Leviste. And also on the phone is the project director for the COA360 and Cultural Quality Collaborative programs, which is Cherie Wilson. Next slide. I'll take this opportunity to mention briefly an upcoming event that the center is sponsoring actually next week. The International Conference on Health in the African Diaspora is a major international conference that we're going to be hosting here in Baltimore. The web address is ichad or ichad.org, and if you're interested, I hope you will go to the website, learn more about this conference, this exciting conference. And this conference is will be an ongoing project. We are hoping to have future conferences on this theme in the future. So if you're not able to come next week, hopefully you'll stay in contact with us either through the website or through our page on Facebook, which is iChat Summit on Facebook, and then we have the same hashtag iChat Summit on Twitter. You can follow us there. You can also follow tweets of the conference during that through Facebook and Twitter. Next slide. We have a series of webinars that we do occasionally that relate to healthcare, different issues in the healthcare industry, and I just wanted to tell you about or mention to you a webinar we recently had. I'll actually turn this over to Cherie and see if she has anything more to say about this. The webinar that we co-hosted with GLAM, Gay and Lesbian Medical Association.
Sure. Thank you, Dr. Leviste. So yes, we just hosted this webinar in partnership with GLAMA last Tuesday, and this is the first of a 4-part series. If you weren't able to attend that webinar, please visit our center's website at www.hopkinshealthdisparities.org or visit the Culture Quality Collaborative's website at www.thecqc.org. The webinar recording is available there as well as the presentation slides. And I will go ahead and turn it back over to Dr. Leviste.
So what's been happening in this country is that we're undergoing a fundamental shift in the ethnic and racial makeup of the country. This chart shows the changes that have occurred for the second half of the 20th century, where the proportion of Americans who report on the census as being non-Hispanic white has been dropping from about 90% in the middle of the century to less than 70% by the end of the century. Next slide. The Census Bureau projects that this pattern will continue throughout the 21st century, and that at some point in the mid-century, the United States will be a majority population of what we currently refer to as racial and ethnic minorities. This has already occurred in 4 states, and there are several states that where we expect that this pattern will occur within the next probably 10 years. So fundamentally, the nation is changing, not only in terms of race, ethnicity, but also in terms of language needs and religion, and we are truly becoming a more diverse country. Next slide. For example, between 1990 and 2000, 15 states have experienced more than 100% growth in their limited English proficiency populations, and in 9 states, more than 10% of the overall population is already of limited English proficiency. Next page. Next slide. So the way that we've addressed this issue in the healthcare industry has primarily been through efforts to improve cultural competency. Cultural competency, here we're talking about cultural competency as a developmental process that evolves over an extended period of time. That individuals and organizations and systems develop cultural competency not as a one-time learning occurrence, but rather as something that is an ongoing learning process, because cultures are dynamic, cultures are always changing, and there's always something new to learn. Not only that, individuals that are members of particular cultures may adhere to certain tenets of that culture, but not necessarily all tenets of that culture. So it is infinitely complex that and vital that we understand the complexity of culture and the complexity of the way that culture manifests among individuals, and in particular within the healthcare system. Next slide. Being a culturally competent organization requires that you have a defined set of values and principles, and that you're able to demonstrate those behaviors and have policies and structures in place that will enable people within that organization to effectively operate cross-culturally, not only with patients but also with co-workers. Next slide. Culturally competent organizations must not only have the value and have a value statement, but also must conduct assessments, we believe, and in other words, approach the topic the way that we approach other issues within the healthcare system. We try to define and measure these issues. We try to see where there are gaps and where we should be or where we'd like to be, and then we try to take steps to improve where we are. If we can form a culturally competent organization, then individuals who come to work within those organizations will, as they become a part of this new organization that they're joining, they will adopt the policies and the practices and the cultural norms and values of that organization, and then we so that we focus not so much on the cultural competency of the individual, but we focus on the cultural competency of organizations, creating an organizational culture that is culturally competent. We believe by doing that, as we bring new people into the organization and that they're mentored into the values of that organization, then those individuals will express through their actions and their words those values that are culturally competent. That is done through a series of policy making, practices, norms, and the creation of norms and values that produce culturally competent outcomes. Next slide. At the same time, while the nation is changing demographically, within the healthcare industry, we're facing dramatic changes in the regulatory environment. Next slide. A few examples are Title VI of the Civil Rights Act of 1964, the class standards and the enhanced class standards that will be soon released. There's also a National Quality Forum. Next slide. Joint Commission, NCQA, meaningful use of electronic medical records, all of which are changes in the regulatory environment that have aspects of it that attempt to increase cultural competency, reduce disparities, increase equity, and adjust with the industry to the changing demographics of the patients that we'll be serving in the coming years. Next slide. The imperative to address cultural competency goes beyond just being the right thing to do. There is no doubt that addressing disparities, improving health equity is the right thing to do, and there is a strong and I think well-justified social justice reason to address health equity, but there is also a utilitarian or economic reason. A report that we published a few years ago in conjunction with the Joint Center for Political and Economic Studies, we calculated the direct medical costs of health disparities or health inequalities. That is, the cost associated with use of health services among people that are sicker than they otherwise would have been had they had equitable care, as well as the indirect costs associated with lost productivity to the economy and the costs associated with premature death. And when we calculated these costs over the years 2003 to 2006, we estimated those costs to be at $1.24 trillion lost to the U.S. economy. So it is certainly the case that while there are costs associated with addressing health equity, it is also the case that there are costs associated with not addressing health inequalities. Next slide. The COA360 is a tool that was developed here at the Center for Health Disparities Solutions to deal with the problem of bringing measurement and scientific rigor to the issue of cultural competency. We had the idea that perhaps we could find a way to help organizations measure or assess where they are in terms of cultural competency in a way that was scientifically rigorous and validated, but also had the ease of use that would make it something that could be used in real-world settings. The COA360 stands for Cultural Competency Organizational Assessment 360. Next slide. The tool was developed as a result of research that we conducted at the center, and here's the front page of the article that we published in Journal of Healthcare Management in 2008, where we conducted a validation study to validate the tool, show that the tool had was scientifically validated. Next slide. And we're also very proud that in that year, 2008, we won the award, Innovation Award, from the National Institutes of Health, National Center on Minority Health and Health Disparities for the development of the COA360. Next slide. The tool is administered by way of the internet. It's a web-based tool. It assesses the cultural competency of healthcare organizations. It is not a measure of the cultural competency of individuals, and I think that's important to stress. We're talking about the organizational culture, not individuals that work in the organization. The tool is designed to identify strengths and also identify areas that are in need of improvement. It's suitable for any size organization, small or large, and it assesses the unique configuration of diversity of the organization. Currently, we address race, ethnicity, language, and religion, and we plan to incorporate sexual orientation into the tool very soon. Next slide. The tool is focused on measuring the class standards, Joint Commission standards, as well as we include the CAPS patient experience survey, including the health literacy and cultural competency item sets. So we call it COA360 because what it does is provide a 360-degree view of the organization from the perspective of the various constituency groups that relate to the organization: the clinical staff, non-clinical staff, the administrators, and patients or clients. So many other tools are assessments fundamentally of the administrators. So a questionnaire goes out to administrators. Administrators answer a set of questions, and you get the perspective on that one group of individuals that relate to the organization. But we thought it was important to have the perspective of all of the various groups that relate to the organization, and in particular the non-clinical staff, which is a group that is often not included. The non-clinical staff is very important, and this was made clear at a recent visit to a hospital where we pulled into the parking lot and noted that the first person that we encountered there at that hospital was the parking attendant. And the interaction with that parking attendant can set the stage for the rest of that encounter for that day. So not only do we have to focus on creating and having culturally competent clinical staff, which is what many organizations do, but we think it's also vital that we focus on having culturally competent support staff, and that cultural competency filters throughout the organization so that the security staff, people working in food services, the receptionists, parking attendants, everyone at the organization understand that they have a role in patient care, and they have a role in ensuring that patients have the best possible experience at the as they visit the facility. Next slide. And here I'll turn it over to my colleague Cherie to take the next few slides.
Great, thank you, Dr. Leviste. So we see the COA360 and the Cultural Quality Collaborative, or CQC, which we'll be talking to you about a little bit later in today's presentation, as part of a continuous quality improvement cycle. So the goal is that an organization would first do an assessment to establish a baseline. And I come to cultural competency and health disparities from a healthcare quality and a patient safety background. And oftentimes organizations or units or departments will jump to the intervention phase without knowing first what their current performance is. And when you do that, you don't know if those interventions you put into place were actually an improvement or a detriment, and in fact, perhaps even made things worse. So when you do your baseline assessment, the assessment report that you receive then will help you identify deficiencies or opportunities for improvements. Once your gaps have been identified, you then need to tailor interventions to identify and to address those deficiencies and improvement opportunities. You then need to implement, give it time to scale or spread throughout the entire organization, and then you would want to reassess during a predetermined period. So that could be anywhere from, say, 6 months all the way out to, say, 12, 18, perhaps even 24 months. And then you begin the process anew. And now we'll turn to a brief demo of the COA360. And the assessment actually has 5 different surveys. There is a point of contact survey. There are 3 different staff surveys, the administrator, clinical staff, and non-clinical staff surveys, as well as a patient-client survey. So we mentioned that this is a web-based survey. So as soon as someone has been entered into the system, if the person has an email address, that person would receive an email, and it would contain that person's name, the link to the assessment, as well as the person's username in order to access their survey. We have found, though, that in some institutions that the non-clinical staff do not have email accounts. So in fact, they're almost relegated to second-class citizenship, especially if we think of how most information is disseminated. In those instances, we don't want those staff members to have to take the survey on paper, so we actually create usernames for them, and if public workstations are available or if there is a computer lab, they can then complete the survey online as well. And when that person goes to the website, they would just enter either their email address or their username. So then when you log into the system, you would click on your appropriate survey. And then this is a sample of the point of contact survey. The first page actually is taken from the American Hospital Association Annual Hospital Survey. And the goal of this is for benchmarking purposes, where as we have more organizations actually use the tool, we would be able to benchmark with like hospitals. So are you a for-profit hospital? Are you a military hospital? Are you a federally qualified healthcare center? And then the point of contact, again, this is the person designated to basically facilitate the administration of the entire assessment. That person is then asked what is his or her perception of, and you can see up top here, the racial or ethnic diversity, religious diversity, and linguistic diversity of the organization. And we ask regarding not just the patients and clients, but also for the service area or the community surrounding the senior leadership, clinical staff, as well as non-clinical staff. And when we get to the sample report, you'll see how this is pulled in, because oftentimes we know that if we're looking at this from a workforce diversity standpoint, we might have a very, very diverse service area or patient or client population, but our organization is not reflecting that diversity. And so when this is pulled into the report, you can see that this is a great way to depict this graphically. Next, we ask about the religious diversity, and we currently include in this point of contact survey the top 5 world religions plus Jehovah's Witnesses and Mormons. When we get to the actual staff surveys and patient surveys, you'll see that we are much more granular because we want to give people the opportunity to actually identify to which religion, if any, they belong. And then lastly, we ask about the linguistic diversity of the organization. So we're asking what percentage of the service area and or patients and clients are perceived to be limited English proficient, and then what percentage of the staff, both clinical and non-clinical staff, are considered to be multilingual. And we ask that last question because this might be a way for you to identify the percentage of staff who potentially could serve as bilingual staff in your organization. But if we think back to the class standards as well as the most recent Joint Commission standards on effective communication, cultural competency, and patient-centered care, in order for those staff to truly be qualified bilingual staff, their language proficiency must first be assessed, and they must undergo some sort of training. Now I'll turn to the staff surveys, and we have 3 different staff surveys: administrator, clinical staff, and non-clinical staff. The questions are the same for each, but you'll see in the report that their responses are reported out depending upon which survey was completed. So across the top here, you'll see we have this first step, which is pulling in information about the survey participants. And as Dr. Leveist mentioned, our assessment is based upon the class standards, the Joint Commission standards, as well as the CAPS experience questions, with several questions pulled from the cultural competency and health literacy item sets. So here where you see steps 2 through 5, these are kind of the overarching themes that we consider, and when I get to that, you'll see that we have a domain name for what would be each of the class standards. But first, we ask the staff participants, a little bit of information about themselves. So, how long have you worked in the healthcare industry? versus how long have you worked for that particular organization. And we ask this question from a teamwork and communication standpoint. You might have worked in the healthcare industry for a very long time, but if you are new to the organization, you might not yet have absorbed or internalized the norms and behaviors that are expected at that organization. And we know that can be detrimental to teamwork and communication. We also ask, what is your position? And if one would hover over the question mark, there is a list of who falls into each of these categories, because it is our intention for this not to just be a survey of doctors and nurses, but we want to include the clerical staff, the transport team, as Dr. Levis mentioned, the housekeepers, parking attendants. They are all part of the team. Again, coming at this from a patient safety perspective, we've all heard about hospital-acquired infections, and I know that working with a particular unit, their hospital-acquired infection rate, or I should say, their rate of MRSA infections was reduced dramatically when they actually included the housekeeper as part of the team. So this is one reason why we really need to include all of our staff in these assessments. The other questions that we ask include, what is the primary work area or unit where you are working? So we want to ensure that we have broad representation from the various units, both clinical and non-clinical. So we have things such as the ED, labor and delivery, patient billing, medical records, or health information management, again, so we can show adequate representation. We ask them questions about whether they've received any kind of training or they have knowledge about cultural competency. This one is helpful. Do you feel qualified to conduct a medical encounter in a language other than English? Getting back to the issue of qualified bilingual staff. One can feel confident that they are qualified to participate, but once their competency has been assessed, that might not necessarily be the case. We ask about gender. And in addition to that, we are currently using, you saw that in the point of contact survey, we used a modified Office of Management and Budget where you had the 5 races and then the question of whether you're Hispanic or Latino. We are using the Office of Minority Health's data collection standards for race and ethnicity to meet Affordable Care Act Section 4302. And if you haven't heard about that, email me and I can send you a link to that information. But what it does is it not only asks, are you Hispanic, Latino, Latina, or Spanish, it parses out, it becomes a little bit more granular and asks if you fall into one of the particular ethnic groups, and then basically, are you another Hispanic, Latino, or Spanish origin not listed previously. They kept some of the Office of Management and Budget with white, black, or African American, American Indian, or Alaska Native. Then, if you see listed here from Asian Indian down to other Asian, they became a little bit more granular with the Asian category and a little bit more granular with the Native Hawaiian or Pacific Islander category, being from Native Hawaiian to other Pacific Islander. With what is your religious affiliation, if any, we actually have a list of 100 different religions and denominations, ranging from if you have no religion, agnostic, atheist, to the pagan religions, to all the different types of Islam, Orthodox Christians, Judaism, Christianity, and within Christianity, what kind of Methodist are you? What kind of Baptist are you? And we'll be able to roll those up into larger categories, but it would be very helpful to know this information from a pastoral care standpoint, because are you actually meeting the pastoral care needs of your patient population? And then lastly, in what country were you born? And then, so to meet, say, class standard 1, we have a domain called Promote Equity and Quality. And for each of the domains, we have questions associated with the particular domain. And then we create a domain score, and you can see how you did overall on that particular domain. We have a whole language services section, so it ranges from who actually provides language services to do you ensure language proficiency, to do you actually notify the patients that they have a right to free language services and that they don't have to bring their own family members or their own interpreter, and also to do you have signage available in multiple languages, and do you have materials translated into particular languages, such as the main vital documents, such as consent forms, billing forms, advance directives, and things of that sort. We then ask questions about the organization. Do you actually have planning related to cultural competency or the class standards? Do you have a committee that actually looks at this? And then, do you have a managerial staff member who is responsible for managing your culturally and linguistically appropriate services? What about the community and consumer involvement? So, do you actually, when you're having your different class initiatives? Do you share that with the community? Do you bring them in as members of your various committees to be patient-centered, patient and family-centered? And then from a patient satisfaction perspective, we have 3 sets of questions. One is patient or client satisfaction, discrimination or bias, and patient-client trust. These are a handful of questions, but from the staff side, we ask the staff to predict how they think the patients will actually respond. And then we ask the patients how they actually respond. And in the report, you'll see where there may be gaps. And then as part of the assessment, we actually, Dr. Levis developed an organizational inclusion culture measure. And basically this looks at some of the top 4 organizational values in an organization, as well as the top 4 organizational processes, or 4 processes within the organizational process. You rank these according to how you think they are ranked in importance by the organization. You see how this shakes out in the actual report. And then what it does is it creates a matrix to let you know in what kind of an organization are you working. Because say if you're working in an organization with long-standing traditions, they've been an industry leader, well, that organization has no impetus to change or make improvements. But if you work in a different kind of organization where they say, well, I don't care what level of the organization you're in, just get it done, even if you are the housekeeper or the nutrition staff, then you need to function in a very different manner to be able to make changes. Now I'm going to turn to the patient or client survey. And as you saw with the staff surveys, we asked questions about the backgrounds of the patient or client participants. So we asked when they were last a patient. And so here, let me just note here, it happens to say City of Hope Hospital. This tool is not just limited to hospitals. We have used it in outpatient settings. We have used it in behavioral health. It can be used in physician practices. It just says City of Hope Hospital because that is the name of the healthcare organization being assessed. Then we asked the patients or clients, what language do you feel most comfortable speaking with your doctor or nurse, when we have a drop-down list of languages. And then recognizing that one's educational level is not a surrogate or a one-for-one comparison to one's health literacy, we do ask about the level of education completed, mainly as this is additional information. We know that our electronic health record systems, for the most part, don't capture this information, but it is helpful to know, and it would be possible to stratify your data by this as well. And then they're asked similar questions regarding their backgrounds as the staff were. You'll see that the survey for the patients or clients is shorter because they were asked a subset of the questions that the staff were asked, because there are certain issues they wouldn't be able to address. So we had things such as promote organizational diversity. Well, the patients might be able to look around and say, well, gee, this doesn't seem to be a very diverse organization, but they would not be able to address the organization has good practices regarding the recruitment, retention, and advancement of minority staff at all levels. And again, you'll see that there are a subset of questions. And as I had mentioned, on the staff side, they are asked to predict how the patients or clients would respond. The patients or clients are asked to actually answer how satisfied are they. Do they think all patients are treated the same regardless of their race, language, or religion? And then lastly, we have a patient experience section of the patient or client survey. It's based upon the CAPS hospital survey, and they are asked to then rate their nurses, their doctors, as well as the other staff. Now we'll give you a brief overview of the assessment report that is generated. And let me say something about the assessment report. So as we said, this is a web-based assessment. And the beauty of this is that when your assessment is completed, if you've had patients complete their patient surveys on paper, as soon as we receive those paper surveys, they've been entered into the system, boom, you have your assessment report. So you don't have to wait weeks and months to actually see your results. Again, coming from a quality perspective, the further away you get from the actual data collection, the less likely people are to look at it, and it's apt to be less relevant. So in the report, we have 3 sections, the first being the organizational diversity and representativeness summary, and that is pulled from the point of contact survey that I showed, but you'll see how this actually is demonstrated in the report. We have a section on the background information of the survey respondents, both staff and patient, and then the meat of the report is the performance domain summary. We also give you an idea of who actually completed your assessment. So we break it down by constituency group, as Dr. Levis mentioned, so how many administrators versus clinical staff, non-clinical staff, and patients. So as we mentioned, this first section is drawn from the point of contact survey. This is the organizational diversity and representativeness summary. And what we see here is, as I said, anecdotally you may realize that your service area or your patient population is diverse, but maybe your workforce diversity doesn't reflect that. So if we use the example of Black or African American and even East Asian, in the case of Black or African American, what this is showing is that 41 to 60% of the patient population is perceived to be Black or African American, whereas 21 to 40% of the service area is perceived to be Black or African American. So that organization can immediately say, oh, we are extremely diverse, until you look and see that 61 to 80%, so that exceeds both the service area and the patients. This tells us that Blacks or African Americans are disproportionately represented in the non-clinical staff. So that means that the majority of Blacks or African Americans in that institution are likely working in housekeeping, transport, nutrition, security, things of that type. But they are not at all represented at the senior levels, so in senior leadership, or among the clinical staff. The same holds true here of the East Asian population. The patients and clients in the service area is perceived to be 6 to 20% East Asian. So whereas they are represented in the same percentage in the clinical staff, they again are not present in the senior leadership, and they also are not employed as non-clinical staff. So this section, this is pulling in the background information from the survey respondents, again, both staff and patients. And this was that question, how many years have you worked in the healthcare industry? This is just showing the range, the low being 10 for administrators with a high of 30 years, with the dot in the middle representing the average or the mean, 20 years. And we do the same for clinical staff and non-clinical staff. You have a similar graph on how long you've worked for the organization, and again, that's getting back to the teamwork and communication culture of the organization. We then pull in information regarding what percentage of staff as well as patients consider themselves to be Latino Hispanic ethnicity. So here I would see that 33% of the non-clinical staff and 38% of the patients or clients considered themselves to be Latino Hispanic. And these are of the survey respondents. And then for each of the constituency groups who complete surveys, so this would be your administrators, your clinical staff, your non-clinical staff, and the patients, we would then show what is the racial background for them as well. But here we come now to the meat of the report, the performance domain summary. So you saw that we had that section, promote equity and quality. For each of the domains, a graph is generated, and in that graph you have 5 different bars. The red bar is representing the employee average, so the average of all of the employee responses. The green bar is the administrator's responses, purple, clinical staff, yellow, non-clinical staff, and blue, the patients or clients. Based upon the score or the rating, some verbiage is generated saying on average how they are doing regarding this particular domain, and then we also provide some commentary and suggested remedies, and this is generated based upon the rating you received. Next, we have this promote organizational diversity, and this is the example I was giving of you notice there is no patient bar because there are no patient questions, because this would be difficult for the patients to assess. They don't know the organizational policies regarding this area. Then we have the sections again of patient-client satisfaction, discrimination bias, as well as patient and client trust. So not only do you receive the graph that you receive for each of the domains, and this actually gives you an idea of how much lower or higher the patient or client satisfaction scores are than those predicted by the overall staff. But then this gives you a drill down, which actually is represented better on this next slide because it's small. It gives you a drill down of where you actually need to focus your efforts. Because if we look at our data in the aggregate on the previous slide, you would have been doing not too badly. But when you actually drill down and you basically review your data by race, ethnicity, language, religion, you're actually basically having the ability to decide where to focus. So what we do is where there has been at least a response by 3 people within each of these groups that you see, we then report out those results. We wouldn't want the one of person in a particular group to have their responses, because people would say, if people knew who actually completed the survey, oh, I know who that is, that's patient X or Y. So if I'm looking at this, this is regarding patient or client satisfaction. I would be very concerned because of my Black or African American patients, as well as my Latino Hispanic patients, I see that 100% of them are either somewhat dissatisfied or very dissatisfied. Whereas if I look at my white patients, 100% of them are either very satisfied or somewhat satisfied. What I would want to do is probably have a focus group with each of the groups, Black or African American and Latino Hispanic, to find out what are some of the issues and what we can do to actually address those issues. Similarly, we also parse this out by language versus those where English is their primary language versus those where English is not your primary language. So you see here that for those where English is your primary language, for the most part, they actually do trust the organization. Whereas those where English is not their primary language, they tend to be much more distrustful of the organization. We also then provide this by religion. And I would look at this, and anyone who is disagree or strongly disagree, I see 17% of the Christians are distrustful or do not trust the organization versus 100% of the other religion. So it could be someone who's coming from a pagan religion. It could be, well, it probably wouldn't be someone who is an atheist or agnostic or had no religion, but it could be just a religion that maybe in that area, you know, isn't viewed as favorably as some of the other religions. Another thing we've seen here is it could be something as simple as regarding patient satisfaction. We looked and we saw 100% of the Hindu population was dissatisfied. Well, could it be regarding the diet? So I'm a Hindu and I happen to be vegetarian, but the vegetarian options you're offering me are inadequate. So you're giving me a California vegetarian diet, so you're giving me avocado and sprouts and something like that, but that's not something I would normally eat. So something as simple as that, but you wouldn't know that until you ask the patient. And I would like to take a moment to thank our group of COA360 certified consultants, Andrea Thompson and Michael Thompson, who are with Marblestone Consulting Group, Nadia Sawaya, Amy Wilson-Strongs, who is formerly of the Joint Commission with Wilson-Strongs LLC, Yolanda Robles of Cultura Link, and Dr. Lavana Blair-Lewis, who is at the University of Southern California. And now I would like to turn to a discussion of the Cultural Quality Collaborative, or the CQC, and how does this fit into our continuous quality improvement cycle. So what is the CQC? This is a learning exchange of healthcare organizations. We engage in co-learning, and by co-learning what we mean is that the organizations are learning not only from the experts here in our center, from our certified COA360 consultants and other cultural competency consultants with whom we are working, but they also learn from one another. They play an active role in the COA360 CQC continuous quality improvement cycle because they participate in the assessments, identifying deficiencies or improvement opportunities, tailoring interventions, reassessing, and then sharing the findings among the members. And where are we currently in this process or in this cycle? So the majority of our members, except for 2, have actually completed their assessments. They have identified deficiencies and opportunities for improvement. So we're actually at this tailoring intervention stage. So what we're going to be working on over the next year is what can we actually do to improve those areas where we've identified gaps in performance. And as part of their membership, what we do is we have monthly webinars on various topics. We actually came to these topics by having a member interest survey. We actually launched in February of 2011. We gave them about 40 or 50 different topics, asked them to rank their interest in learning more about that topic, and so these topics are presented in the order of the interest of the CQC members. What we typically do is on our various webinars, there's usually an expert's presentation, and it's not necessarily someone from our center. And to give you an example, we had Amy Wilson-Strong speak about the Joint Commission standards. We had someone from the ARC Innovations Exchange speak about this particular program. We had Darcy Graves from SRA International talk about state laws and regulations regarding cultural competency. In addition to that, we had Dr. Leviste and Dr. Daryl Gaskin talk about that economic burden of health inequalities report, which he referenced earlier in the presentation. and we had a presentation from Gail Tang from Kaiser Permanente, and she spoke about their Qualified Bilingual Staff Program, which actually has been around since 2003. And I'd like to thank our CQC founding members, and they are Henry Ford Health System, which is in Detroit, Michigan, Sinai Hospital, which is in Baltimore, Maryland, Johns Hopkins Bayview Medical Center here in Baltimore, the Johns Hopkins Hospital, also in Baltimore, Lakeland Healthcare and their 3 hospitals that are participating, so Lakeland Regional Medical Center in St. Joseph, Michigan, Lakeland Community Hospital in Niles, Michigan, and Lakeland Community Hospital in Waterfleet, Michigan. St. Elizabeth Regional Medical Center in Lincoln, Nebraska, and then 4 of the Catholic Health East hospitals. Catholic Health East is a health system that is located on the East Coast, and 4 of their hospitals are participating. Holy Cross Hospital, which is in Fort Lauderdale, Florida, Mercy Philadelphia Hospital in Philadelphia, St. Mary Medical Center in Langhorne, Pennsylvania, and St. Francis Hospital in Wilmington, Delaware. And we are seeking to expand our membership. And let me see. Dr. Levis, did you want to jump in here, or do you want me to continue with the satisfaction results?
We're coming to the end. Continue.
Okay, very good. So we just want to share with you, since we've been around for a year and a half now, what do people who have actually taken the COA360 as well as have participated in the CQC think of their experience? So first, let me talk about the COA360 satisfaction results. So basically, after completing the COA360, users are invited to take an optional user experience survey. So we've actually had several thousand people participate, and for the user experience survey, we had almost 400 people. So you can see that the majority of the people strongly agreed that they were satisfied with their overall COA360 experience. Regarding satisfaction with the functionality of the tool, the majority, again, were strongly agree or agree. Satisfaction with its usability, majority strongly agree or agree. And just some qualitative results from people who have taken the COA360. This one states that the COA360 has given them detailed insight related to their cultural and linguistic competency in a variety of domains, and it's allowed them to determine targeted steps they can take in order to provide more culturally competent services to our clients. So think of the domains that you saw in the reports as well as in the survey, but also this indicates how this is part of this continuous quality improvement cycle. Next, this was an organization where they wanted to launch a unit-based educational program. And so what they did is they used the assessment to establish a baseline prior to launching the unit-based educational program, and they aligned the assessment results with the goal of improving patient satisfaction, employee engagement, clinical quality, and organizational cultural competence, which was in their labor and delivery unit of their hospital. And they felt that if their intervention was successful, they could then roll it out to other units in the hospital. And I have to say, too, is one of our hypotheses is that units or organizations that exhibit a high level of organizational cultural competence, that they also perform highly in other realms as well, whether it's quality, patient experience or satisfaction, employee engagement, and patient safety. The COA360 was described as being innovative, user-friendly, easy to understand for patients, staff, and leaders. The report was thought to be very helpful with meaningful results, thorough data analysis, and helpful recommendations. And this organization felt that the information provided was critically important to the hospital, given that this happens to be a hospital with a patient base that has a wide variety of races, ethnicities, and cultural backgrounds. And then I'll turn briefly to the CQC satisfaction results. So again, I mentioned that we are 14-member hospitals, so we had at least one person from each of the organizations complete the CQC member survey. So a high percentage were very satisfied or somewhat satisfied with the CQC thus far, and again, we've been around for a year and a half. The majority, actually all except one person, would recommend, and we hope to please just about everyone, but sometimes your best efforts don't work, or we could always try to do better. And the most useful aspects of the CQC were thought to be a combination of the webinars, learning from other providers, so that's again the co-learning we were talking about, access to the COA360 assessment tool, learning about what other organizations are doing, again the webinars, and then developing a knowledge base and where this person doesn't normally focus his or her attention. So let me mention something about that. We have a CQC listserv. We have a little over 100 people on our CQC listserv, but remember we only have 14 member hospitals. So what we have is there's a slightly different model at each of the organizations, but some of them have one person who participates in the webinars. Others have a team-based model. So if it's a topic that would be of relevance to their language services coordinator, that person participates. If it's about data collection, the quality people participate, or the registration staff. So basically, we're trying to disseminate the information to those to whom it would be most appropriate. And then the balance between the academic and practitioner examples, the diversity of topics, resources from speakers and especially from the other members, access to the seminar information, and again, as part of this continuous quality improvement cycle, the identification of barriers to implementation. So now we would like to open it up for Q&A. And let me look at some of the questions that we've received. Okay, so one of the questions that we received is, can this tool be utilized in behavioral health settings as well? And yes, we actually have had this tool used in a behavioral health setting. And so it's applicable to, as Dr. Levy said, any size setting. So you could use it in a unit or department, or you could use it in your entire organization. We actually have 2 different tools. You can use it to assess, say, a behavioral health setting. So it could be the inpatient behavioral health unit. It could be an outpatient behavioral health clinic. It could be an ambulatory surgery center. It could be a physician practice. So as I mentioned, it's been used in both clinical and non-clinical settings. So we've had people assess patient billing, housekeeping, security as well. And if you would like to ask a question, you may feel free to either type it in the chat or Q&A box listed, or if you raise your hand and you actually did enter the audio pin, I can unmute you and take your question as well. So if you raise your hand, I will take questions in that manner as well. Okay, another question. And Dr. Louise, feel free to jump in at any time if you'd like to answer one of these questions.
Sure.
Does your model take into account the pastoral care at a healthcare organization? So I would answer that question 2 ways. So we consider from a survey completion standpoint, I consider pastoral care part of the healthcare team. I would actually include them as clinical staff because they are working directly with the patients. So 1, I would see them as completing a clinical staff survey. We also have a question in there that asks, were your pastoral care needs met, or were your spiritual needs met? So yes, we do actually cover that. Okay, let me take some of the other questions here. Okay, Dr. Levice, you might want to take this one. It says, can COA360 be utilized to explore organizational culture of organizations of healthcare professionals, like membership or associations? So I'm guessing this might be like the various healthcare professional associations in the field.
Huh. Well, that's an interesting question. You know, it could be used in any organization that has practices and policies that relate to the topic areas that we cover. So I don't know. I'd probably want to talk to that person a little more to learn more about the organization and exactly what they're engaged in before I would say that. But so I won't say no, but I'd say I'd want to have a little more information about the specifics of the organization. It was really set up to deal with organizations that have clients or patients, and it's really about how that organization's policies are set up and its procedures are set up to address the cultural needs of those patients. So it might be interesting. We've had many different types of organizations that have asked this type of question, and we've been able to actually apply it to. I've been surprised at the number of organizations where we have been able to use it effectively. So I don't want to say no, but you know, I'd have to learn more about what that organization is doing.
Okay. Great, and if it helps too, for those who ask questions, it tells us who asked the question and we can follow up with you individually about your specific question, such as the one that was asked previously. We have another question. It says that we plan to include sexual orientation in our assessment tool. Have we considered including people with disabilities? And I didn't know, Dr. Leviest, if you want to take that one, but I think that's an excellent question, and as we have better ways to ask these questions, so for example, the issue of sexual orientation, the U.S. Department of Health and Human Services Office of Minority Health, which puts out the class standards, they're the ones who put out the new data collection standards for Section 4302 of the Affordable Care Act. They do have a couple of questions on one's disability status. I think it was talking about are you limited in your activities of daily living, and a few questions about that. So that is definitely something to consider. And as, again, better measures of asking these kinds of questions exist or are developed, our plans are to incorporate those into the tool as well. Dr. Leviest, I didn't know if you wanted to comment on that one.
No, I mean, it is an interesting question because this is a population that I have great personal interest in. It's something that we hadn't really considered, but that may be something that we really ought to look at. I know that there are very serious issues in terms of accessing health care and finding providers who are able to deal with and trained properly to deal with patients with disabilities, and I know that mainly through personal experience with family members. So I'm going to give that some really serious thought, but currently that functionality is not in the tool.
Right. Oh, good. I see we have someone who has a hand raised. Let me unmute her. This is a question from Jacqueline Thomas Hall. Jacqueline, can you hear us?
Can you hear me?
Yes, we can.
Can you hear me?
We can. Go ahead.
Okay. I did send a question through, but I wanted to know how do you coordinate getting the survey in front of your patient population?
Oh, excellent. That's an excellent question. Let me mute you if you wouldn't mind taking it then offline. Okay. So how we facilitate the administration of the survey to the patients. So with the organizations with which we've worked so far, they've used a variety of methods. So some have actually done real-time administration of the patient surveys. So the patient presents to the ED, and as part of, say, the registration process or the triage process, the patient receives a paper survey that has a cover letter explaining the survey, and then they're given the survey. And then there's an option to either drop it in a box at the end of the encounter, or they're given an addressed envelope, which is then sent to our center as a third party. So that's one way. Another way is that some people, again, give the surveys and tell them they can mail them in. Another organization has specifically basically gone through and looked at maybe the last 30, 90, 6 months worth of discharges, and because they really wanted to reach a very diverse patient population, they ended up almost oversampling for certain groups because they figured that they might not have a large or high response rate. So that's another method. Another hospital wanted to really reach its Latino Hispanic population, and what they did is, although for the unit assessment we actually had the patient surveys translated, they of course were available in English, but they were translated into Arabic, Vietnamese, Russian, and Spanish. And the organization-wide assessment, we will translate the patient surveys into various languages upon request as well. What they did, rather than just having those patients, the Spanish-speaking patients, complete the paper surveys, there were issues of literacy. These patients did not read Spanish, never mind reading English. They actually used one of their interpreters to call the patients over the phone, walk through the survey over the phone in Spanish, recorded their responses, and sent those surveys to us. Does that answer your question, Jacqueline? I just unmuted you again.
Does that answer your question, Jacqueline? I just unmuted you again.
Did it?
Yes.
Yes, good. Thank you. Okay. Anyone else have a hand up? Okay, well, we have a number of other questions. So one of the questions we have is, how long does it take for someone to complete this? So For the actual survey respondents, again, we have two tools here, a unit or department-based assessment, and we have an organization-wide assessment. So the unit-based assessment is a little bit shorter because some of those questions you saw, like what is the diversity of your board, do you have a diverse board of governance? Well, that's not something that can be answered really at a unit level because they have no control over those issues. So for the unit assessments, it took about 10 to 15 minutes for staff to complete and about 10 minutes for patients to complete. For the organization-wide assessment, it's a little bit longer. So I'd say for patients, I'd say about 15 minutes, and for staff, 15 to 25 minutes. One thing I did not point out when I was doing the brief demo is that the survey does not need to be completed in a single sitting. So your assessment period could be as short and as long as you would like. So it could be 2 weeks, it could be 6 weeks. But for whatever length of the assessment period is, that person's survey is available. So if I decide, well, I have 5 minutes now, I'm going to take, get through the first or second screens. If I save it, the next time I log in, I can pick up where I left off. My responses were recorded, and I can continue. Let's see. Okay, we have another question, and it says, is it possible to look at results like this longitudinally? Would you be able to ask a subset periodically versus the entire survey one time? So, Dr. Levis, I didn't know if you wanted to comment on that.
Yeah, by subset, I'm not sure if they mean a subset of the questions or if they mean a subset of the employees or staff and patients. But so I'd like to get that clarification. But the way that this is designed, we would hope that you would use it at least as a benchmark and then as a follow-up after some intervention. So the way it typically has been used is an organization has a plan to do something, make some change in their procedures or policies or develop a campaign or do something that relates to health equity. You do the assessment first, you then do the program, and then you reassess and see if you've made change. And this is the CQI process. So under that process, you would be doing these periodic reassessments as you're making change and monitoring what progress you're making. So, I mean, I think ideally you'd want to do it that way.
Right. And I also didn't know, you mentioned this as part of a CQI perspective, so I'm wondering if they're thinking for benchmarking purposes also. So when you do your subsequent assessment, you'd be able to see, well, this is how we did the previous time, this is how we're doing now. And, oh, another thing I should have mentioned is that you saw the different categories we were asking regarding race, ethnicity, religion. We do have the ability to keep all these questions, but you can add a customized group. So if there is a new group that has moved into your area and you want to see, well, what are our results according to that particular group? So do we have staff members who are part of that group? Do we have patients who are part of that group? We can add that as well. So it could be something like sexual orientation. It could be we have a new ethnic group that came in. There's a new immigrant or refugee population. Oh, we have this religious group. So keep that in mind as well. So I see we have a hand raised, and it's Aileen Seoani. Or Eileen?
Yep, hi, can you hear me?
Yes, I'm sorry, is it Eileen? Aileen?
Yep, Eileen.
Eileen, okay, thank you.
Was wondering, patient and family advisory councils, sounding boards, those kinds of structures, are there any metrics, any studies that show their effectiveness or ways to ensure that these are more effective?
Yeah, that's a great question. So yes, I know that the existence of patient and family advisory boards have been advocated for a while because we've been throwing around this whole concept of patient and family-centered care probably for almost 10 years now, if not longer, even though we know we're not truly a patient and family-centered health system. I personally have not seen any metrics, but I see your contact information here, and I can look into that and get back to you.
That would be wonderful. Thank you so much.
Okay, very good. Thanks for the question. Okay, let me take another question here. Oh, okay. Yes, this question gets into what we were talking about, being able to customize slightly. So question was, is the survey modifiable to address departments where patient care is run by physician assistants so that the survey can be more relevant than asking patients only about physicians and nurses? And Dr. Levis, I think that gets to that CAPS section. where it asks about nurses, physicians, and staff. Now CAPS actually, they happen to limit theirs just to physicians, nurses, and staff. But that's something that we could consider. So that's a good suggestion. Appreciate that one.
Yeah.
Yes, this is a good question too. And we've had this asked several times. The question is, has the tool also been used to survey boards of directors for healthcare organizations? So I'll let you address that one, Dr. Luis.
Well, yes. So you certainly could. So they could be included as part of the administrative leadership of the organization, and so that could happen currently. And this is something that's come up several times, and we didn't want to get too much into kind of future plans, but there is definitely a future plan to add an additional questionnaire that would deal with senior leadership as distinct from the administrators, and that would include boards.
Great, thank you. This next question was, and I addressed part of this, but I want to address the other part of the question. It says, is the tool translated into various languages for LEP staff and patients? So I had addressed the portion regarding the LEP patients. We currently have not yet translated it, the staff surveys for the LEP staff, but Dr. Leviste, I didn't know if you wanted to comment on that one.
Yeah, I wanted to say, the way that we handle the translation is that we translate as we're requested. So if a user has a request for a particular language and for a particular questionnaire, we will make that translation. And we've currently translated it into the patient. We've only received requests to have the patient questionnaire translated into other languages, and we have translated that. We have not yet received a request for staff, any of the staff questionnaires. But if that request comes, we will make that change. And Sri, could you share what languages have we translated so far?
Yes, the languages translated so far are Arabic, Russian, Spanish, and Vietnamese.
Yeah.
Yes. So, okay. Oh, good. We have another hand raised. And this is Rosalie Correa de Arrojo. Rosalie, I hope I said that correctly. Can you hear us? Rosalie? Okay, Rosalie, we can't hear you. If you wouldn't mind typing your question. And if we don't get to your question during the call, I will look through the questions and respond to you individually. Great. So let me get to another question here. Let's see. Oh, okay. This is an interesting question. How could this tool be used in pay-for-performance programs or value-based purchasing? Tom, did you want to address that? I mean, do you think there might be applicability?
Well, I mean, in the sense that an organization is trying to improve quality and by way of reducing disparities in the quality, and I guess it could be used in that sense. It's a tough question. I don't have a specific answer for that question. But the idea is that this is to do an evaluation of where the organization is and how it might improve its performance. So in that sense, it could help with pay for performance, but it's not currently, we don't currently have it linked with CMS or any other entity that's involved with pay for performance.
Okay, great, thank you. Here's an interesting question. And it says, let me just scroll up here, sorry, trying to look through everyone's questions. Okay, so this one says, I am a community health worker at a federally qualified community health care center that serves patients of 27 different languages. Our CEO seems to think that that itself makes that particular organization culturally diverse. I am not so sure of that personally. How do I engage leadership or engage this particular person in discussion on testing our diversity using the CQC or the COA360? And I'm sure a lot of people have similar questions. So, people hear about these, assessments or different ideas and tools at conferences, but how do you actually get your senior leadership to actually want to do something like this? So, Dr. Leviste, I didn't know if you wanted to address that or if you want me to take that one.
Well, since you've given me the option of letting you take it, I'll let you take that.
Oh, okay. He's punting the football to me. Okay. Thank you.
I'm going to punt it.
Okay. So what I would say is what we typically do is when I receive an inquiry, I will usually have a web meeting or a conference call or in person if it's local with a person who expressed an interest. But oftentimes that isn't the person who's the decision maker. And so we are always willing to do a similar presentation. Obviously it would be shorter or longer depending on the time frame you have, to senior leaders and to the management team, or if you have a diversity council or a committee that is charged with these efforts. So I could follow up more with you offline to offer concrete examples of how we might be able to get the person interested in doing some sort of assessment.
Yeah. Well, one other strategy I would suggest is if you could identify in the organization a champion, someone who is in a leadership position, or at least a person who is prominent in the organization, who has a certain heft or stature within the organization, and if that person who might be more amenable to addressing equity issues, or at least being open to considering the possibility that an assessment might be a good thing to do. I mean, another argument to make is that if the CEO feels that the health center is so culturally competent, then how about doing an assessment to see where they stand compared to other organizations, and see if they're able to, if they really are one of the leading organizations, and they might be.
Right. Okay, I'm checking to see if we have any other questions, and if you do have any other questions, again, feel free to raise your hand. If you haven't activated your audio pin, you won't be able to speak. So feel free either to raise your hand so we can take a verbal question, or if you type in your question, I will see it here in my question box. Well, I'll take a couple of the other questions that we received prior to the webinar, and they're partially related to the COA360, and this is some of the stuff that people should be looking at regardless of the tool that they're using. So the question was, what is the most effective way to directly measure race and ethnicity? So I don't know if by measure if they actually meant collect, and we know that that's a long-going debate and discussion. So it depends. If your organization happens to be one who is trying to abide by the meaningful use of electronic health records, it's pretty much been spelled out that for now you need to comply with the Office of Management and Budget guidelines. So that is the 5 racial categories, and then asking if one is of Hispanic or Latino origin. But we do know that there are best practice hospitals across the country and healthcare organizations across the country who are going beyond the Office of Management and Budget, and they're collecting granular ethnicity. So it's not just, are you Latino Hispanic, and that's the only ethnicity. They're even divvying it up to, are Black or African American. So are you Jamaican versus American-born Black versus from Ghana? Or are you, from another particular ethnicity? And I would say that if you're interested, I would look at the state of Massachusetts as a model. In 2006, the Massachusetts Department of Public Health came up with a list of granular ethnicities that were most frequently found in Massachusetts, as well as languages. So rather than each Massachusetts hospital or healthcare organization trying to reinvent the wheel, they basically came up with that information for them. So I would highly suggest that. And let's see. Okay, another question, and Dr. Leviste, I'm going to give this one to you, and it's not just about assessment, but it does fall into something that we do assess. It says, how do we get all staff on board, including management staff, on the importance of training on cultural diversity?
Yes, I think that's another key question. We have another one of the projects that we're doing. We went into the IQI quality indicators and identified high-performing hospitals that were minority serving. That is, more than 50% minority patients, Black or Latino patients, but were high-quality, high-performing hospitals. And we went out and visited those hospitals and spent a day there meeting with the staff, leadership, and others at the hospital to try to get an idea of what were best practices, what were these hospitals doing that was producing these great outcomes that they were having when many other hospitals with a similar patient mix are not able to produce these quality metrics. And what we found was that it really was a top-down process, that it was places where leadership had, the leaders there had decided that they simply were going to be a high-performing hospital, and they were able to infuse that idea throughout the organization from the top down. So I would say the way to really get the people on board to do these things is through leadership. If the people not in leadership in the organization can convince at least someone in the C-suite or someone who has the ability to influence the C-suite, perhaps even the board of directors, to that this is an important priority, you know, that's, in my experience of the hospitals that we studied, that seemed to be the strongest indicator. Can you get someone in leadership, some individual in leadership, to take ownership of health equity? And that was the strategy that we saw as being most effective.
Excellent. Very good. Oh, okay. Here's a similar note, Dr. Leviste. It asks, what are some specific programs or practices that a state agency or state hospital should have in place to ensure culturally competent care? So I'm going to punt that one to you, but again, I'm thinking of our, CQI process and probably addressing it via that way. But go ahead.
Yeah. Well, I mean, I think you're right. It's been sort of a pet peeve of mine that when it comes to health equity, we do things differently often than the way that we do everything else in the healthcare industry. In the healthcare industry, we tend to be very scientific and methodical in the way that we approach a lot of things. We tend to try to define things, measure things, do interventions, do reassessments, kind of a pre-test, post-test approach. And that's the way we generally approach problems. But when it comes to this topic, we don't do that. We just, sort of do things without any evaluation. We do things without any evidence base. And what we're trying to do here is to use those same approaches that we use to other areas, other things that we do in the healthcare industry here. So I've kind of lost track of the question.
Yes, I'll repeat the question. Sorry. It was, what are some specific programs or practices a state agency or state hospital should have in place to ensure culturally competent care?
Yeah. So the issue is really about best practices and evidence base, and that's kind of where I was going with this. Is that we haven't really developed a strong evidence base in cultural competency as we've done in some of the other areas, and that is precisely what we're doing with the CQC. The point of the Culture Quality Collaborative is for us to first identify gaps, identify areas that need intervention, and then try to innovate interventions along with evaluations to document whether or not we're making change. And through that process, start the creation of an evidence base in cultural competency, something that's missing. So at this point, we don't have the strong evidence base. I can only give you a couple of examples of best practices that I've seen from the qualitative study that we did by visiting the hospitals and doing those meetings. And again, I would say it's been the best practices I've seen are leadership who are committed and who are able to infuse an understanding in the organization that this is a priority. We had some leaders that we encountered actually establish policies for hiring that ensured that people that they were hiring understood the importance of health equity, understood that was a highly valued organizational value. Most of the organizations that we studied had mandatory cultural competency training for all staff, and either as part of the employment process when they're first hired, or in some cases as an ongoing requirement that they do cultural competency training. Other organizations had policies in place where they provided incentives for staff and teams of staff who came up with innovative solutions to problems that they saw within the organization. These were some of the strategies that we saw and that I would say are best practices.
Great. Well, I realize that we are now at the end of the webinar. We're actually at 4:30 and we'd like to end on time. First, I'd like to apologize for the technical difficulties again at the beginning of the webinar with the phone number that wasn't working, but I'm glad the majority of you were able to get in and participate in the audio portion. Again, this webinar was recorded, and the webinar link as well as the slides will be available on our center's website as well as the Cultural Quality Collaborative website. No worries about frantically trying to write down a URL. You will receive an email following the webinar with both an evaluation of today's webinar, and I would highly encourage you to complete that. We appreciate the feedback, and we use that to provide higher quality webinars. And also if you have any suggestions for other topics. So please complete the webinar evaluation, and in that email it will provide the link to our 2 websites to where you can access the slides as well as the webinar recording. So with that, I'd like to thank you all for participating, and I hope you'll be able to join us on future webinars. Thank you and have a good afternoon.